Good afternoon, students. So, we have seen in earlier class how to go for diagnosis, how to go for understanding various types of how to diagnose various types of insomnias, and on that so we have seen this flow chart for the diagnosis of different type of insomnias, and what are the basic inputs which has to be considered, and accordingly if we go for that, then we can diagnose it as a that particular type of insomnia. Let us see various insomnias. We'll go quickly about it. We can classify them. First is adjustment insomnia, or it is acute insomnia. It is with the indefinite, there is a which is not identifiable. So identifiable stressor like psychosocial, physical or environmental disturbances. It has a relatively short duration. It is for some days or week, and it is expected to resolve when the stressor is resolved. And it can be anything. It can be, as I told you earlier, it may be like having a problem of new place, new bed, even new type of mattresses, etc. So anything is there accordingly, or as I told you, psychosocial, physical or environmental disturbances are there. Then psychophysiological insomnia, this is heightened because of the arousal and learned sleep preventing associations. Arousal may be physiological, it can be cognitive, it can be emotional, or characterized by muscle tension. So the thoughts are coming, too many thoughts are there, we call racing thoughts, or heightened awareness of the environment. Individuals typically have increased the concern about sleep difficulties and their consequences. So it leads to a vicious cycle. That is, I told you earlier also, vicious cycle means arousal. Arousal causes decrease in the sleep. When the person is aroused, then again having some thinking or racing of thoughts. Because of that, again disturbances as sleep. And eventually we have seen that whenever there are psychological disorders, at that time decrease in the sleep causes increase in the psychological problems, and when presence of psychological problems can cause reduction in sleep. So both are working hand in hand, and they go on increasing if we are not intervening the cycle. Then next is paradoxical insomnia. The essential feature of this is the complaint of the severe or nearly total insomnia that greatly exceeds the objective evidence of sleep disturbances, and it is not going along with the reported degree and daytime deficit. The paradoxical insomnia is the best diagnosis with concurrent self-reports and the evaluations. It can be diagnosed on the clinical grounds also. This misrepresentation, misperception of the severity of these sleep disturbances may also characterize all insomnia. So whatsoever are not exactly diagnosed, we can put into it. Idiopathic is which has not been diagnosed, or where the cause is not known, and in that case it is there. Due to mental disorder, we have seen that in various hello? Ha, Mansi? Hello? I'm sorry, I think, hello?
Yes, sir.
I think my mic was not on, I suppose. Okay,
Yes, sir.
okay, I'll just do it again.
Yes, sir.
So last time we have finished with this chart, and that was for the diagnosis of the chart. That chart was giving various diagnostic feature, and on the basis of questionnaires, on the basis of yes no, we have gone for various assessment steps, and on that basis of these steps we have categorized various kind of insomnias on the basis of diagnostic. Let us go somewhat in more detail, or some more information about these various classes of insomnia. So these are various classes. These are based on the this International Council of Sleep Disorders, ICD-2 insomnia. So International Council for Sleep Disorder that makes these various kind of sleep disorders. These are the types of various sleep disorders. So first is adjustment type of disorder. Adjustment is because of the presence of insomnia, which is association with the identified stresses. It may be psychosocial, it can be physical, it can be environmental disturbances, and we have discussed it earlier. Example is new place, new bed, new environment, new place. In that case, even in at many places, people, if their room is changed, bed is changed, sometime even bed sheet is changed. So like that, many such things are there, or changes in the environmental conditions are there. So these are having this adjustment type of insomnias, and it is very short term. It can be for days or weeks, or even if the person goes back to that particular environment, uh, it is automatically resolves. So this stressor, once it is there, once it is resolved, it is okay. Psychophysiological are there. These are the type of sleep disorders where there are increase in the arousal and sleep preventing associations are there. So both are coming together. Arousal may be physiological, cognitive, or emotional, and they are characterized by muscle tension. So people get stressed, and because of that, there is a muscle contractions. There are racing through thoughts are there. The thoughts are too much. Thoughts are coming, and there is a heightened awareness of the environment. Individuals typically have increased concern about the sleep difficulties and consequences. So the person is not getting sleep, the person becomes concerned. Because of that, thinking again too much, or increase in the thoughts, and particularly why not sleeping, then it comes again. So there is a vicious cycle of arousal, poor sleep, and frustration, which further causes arousal and poor sleep, and again frustration. So it goes on, and it affects sleep too much. Paradoxical is it is a severe or nearly total insomnia that greatly exceeds the objective evidence of sleep disturbances, and means the objective of sleep may be very less, or the evidence which causing sleep disturbances is very less, but the outcome is very high. That means, even just like I told you in earlier cases, adjustment insomnia, that person has got change in the place, change in the environment, change in the bed sheet, change in the bed, something like that, but that should not affect it longer. But if it is affecting it longer, or the whole night, then it becomes a paradoxical insomnia. It is best diagnosed with the concurrent evaluations, self-report, and it can be presumptively diagnosed on clinical grounds alone. This misperception and severity of sleep disturbances may characterize all these insomnia disorders. Idiopathic, already we have seen that when we do not able to find out a concrete reason behind it, then we'll call it as idiopathic, and it is not we cannot correlate with any kind of specific precipitating or perpetuating factors. Particularly during infancy or early childhood, they are more common. Then insomnia due to mental disorders, we have already seen, and we have seen that it has been linked with the this these are more common in psychiatric diseases, maybe schizophrenia, maybe depressions, etc. And we have seen that both are affecting each other. That is, because of mental disorder, there is a lack of sleep, and because of lack of sleep, there is an increase in the chances or severity of the mental disorder. And again, we have seen that it is sort of a vicious cycle, and we have to break it. Simultaneously, we have to go for a treatment so that the person can have adequate sleep, and simultaneously treatment for the diagnose this psychiatric disease which is diagnosed. Then inadequate sleep hygiene, this is also we have seen earlier that there are practices should be there. We have seen that so less daytime sleep, and go for sleeping, avoid the things like drugs, caffeine, nicotine, etc., and engage in the non-sleep behaviors in the sleep environment. Then sleep hygiene is very important. If you remember, we use this word that earlier days most of the activity they were stopping early. Once evening is there, after evening, once they had food, early food, even late food can be affecting sleep, because the body's physiological attention goes, that is internal, goes towards the digestion of food if it is a late night food. But if it is food is taken early, then the digestion and all process they take timely. So there are many things which are there: food timings, then cut off from other activities, go off from the screen, go from various audio visual stimuli, go away from various kind of any kind of other things like alcohol, caffeine, nicotine, etc. So don't engage in this, don't engage in any kind of thinking or this any such activity which will cause arousal. So go according to make it. Insomnia due to a drug or substance, then again it can be caffeine, alcohol, it can be any environmental toxin. Example, in some places gases are released in the environment from the nearby factories. So these are there, and check out about it and try to avoid it. Check if you avoid it, then see the effect. If the effects are or insomnia is reduced, then we can assume about the things that it is because of that particular drug, substance, or environmental factor, and accordingly we can take care in future so that it is not there. Insomnia is expected to resolve or substantially improve if we go away from these particularly identified substances. Insomnia due to medical conditions, these are because of the coexisting medical disorders or other physiological factors, and these are associated with the many medical conditioning. We have seen that this psychiatric diseases, but it is some other diseases which are there, which are affecting it simultaneously, and they are require separate clinical attention. The diagnosis is not used to explain insomnia that has course independent of the associated medical disorder, but it is not routinely made in the individuals with the usual severity of the sleep rhythm. So suppose there is other medical condition, example is a cardiovascular problem, angina like condition. Okay, so it is known. As such, it is not known that angina can affect insomnia or it can cause, but because of angina there is a pain simultaneously. Once it is known or it is diagnosed, then person will have worries. So these worries and this anxiety and this pain, they will cause. So it is a medical condition. We are making it different than the medical condition which were there because of this psychiatric condition, because it is a known factor. Okay, here it is not, that way it should not affect, but here it is affecting in other way. That is simultaneously it is causing stress, it is causing some pain, and accordingly it is there. So this has to be checked. And insomnia which is not due to substance or known physiological condition unspecified, so this is last category, which is neither idiopathic. Idiopathic was also not diagnosed, but usually, as we have seen, that it is in occurring during infancy or early childhood, and these are more chances in younger ages. But this is the last type of insomnia which is neither due to substances nor due to known physiological condition. It is totally unspecified, no organic insomnia, and in that cases the last one category is there of that insomnia. Now the very important and very clear situation is, once we can classify it, once we can diagnose it, then the best thing is identify the cause and try to remove the cause and try to treat the cause, because cause is basically responsible for the problem. So we are going for this causal assessment. We have seen that what kind of cause it may be, and accordingly we are going for various treatments. So first is, once we have identified that there is insomnia, what kind of insomnia it is, then check it whether it is insomnia that is comorbid with other sleep disorders or any other disorder which can affect sleep, and check out whether it is a primary insomnia, because there is no other causes there, and insomnia which is comorbid with the medical or psychiatric or drug related things. So these are three broad classes we have made. We have got so many classes earlier. Out of that we have gone for a broad classes, that insomnia comorbid with other sleep disorder, primary insomnia where no cause is involved, and the insomnia which is involved with medical or psychiatric or drug dependence related insomnias. Now what we are going to do for that? So optimize treatment for other sleep disorder. So if there is other sleep disorder which is simultaneously there, and try to make it check out. If it is improved, then continue that optimized treatment till you get a resolution of it. If it is not improved, then evaluate insomnia treatment options. So what are various treatment options? We have seen various options. One is pharmacological option and non-pharmacological options. So check out various treatment option, check the cost, preference and availability or viability of it. Then we shall see what is next to be done. Here again, if it is insomnia which is comorbid with the medical condition, psychiatric or drug dependence, again optimize treatment for comorbid disorder. Means, example, if it is a psychiatric disorder like depression or schizophrenia, then make the treatment and check whether it is improving the sleep. If it is improving, it is satisfactory, then continue with that. If it is not, then again go for almost believe that it is sort of primary insomnia. So basically what we are doing is, in both cases, left and right side, if we check, we have tried for the comorbid condition and we have tried for comorbid condition treatment first. If it is helping out, it's fine. If it is not helping, then we are considering it at par or almost similar to that of primary insomnia. Then we are going for the treatment of this insomnia, considering as if it is not because of any comorbid condition. So let us go for that. What we are going for that? So once we get it, we have got three options. We have got combined treatment, we have got psychological and behavioral treatment and pharmacological treatment. What we are going to do for the first one, if it is milder condition, always we should prefer for non-pharmacological treatment, that is psychological and behavioral treatment. Here we are giving cognitive behavioral therapy. If there is an improvement, then we'll continue it, and follow up with the periodic review of that. If efficacy is okay, we can continue it. If not, then accordingly we'll go for other treatment. Okay, so we are observing it, we are taking the review. If the prognosis is very good, then we do not need for having any kind of pharmacological treatment. Then second is combined one. Since this CBT is good one, it can always be combined or it can always be planned for this to have both simultaneously wherever it is possible. If it is not possible, then okay, we cannot do anything. But if it is possible, example, we may not able to go for in psychiatric patients for this cognitive behavioral therapy, or those which are very young, very small one, then it may not be possible for that. So wherever it is possible, first uh, first line will be our cognitive behavioral therapy. If not improved, then we are going for the pharmacological treatment, or we are again, if, when cognitive has shown no improvement, then what we are doing, we are adding one more thing along with cognitive, where your cognitive is possible. So considering switching to other modality for or combined treatment, and then if it is not useful, still it is not giving any kind of good signs, then maybe our diagnosis was wrong. So go for again re-diagnosis, re-evaluate specifically for occult or comorbid disorders, whether there is any problems in the brain or any comorbid disorder which was not identified earlier. Check it out. Now, if it is there, uh, add the behavioral treatments as for that. Then if it is improved with addition in the behavioral treatment, there are many behavioral treatment are possible. So if that it is improved, it's fine. If not improved, then again this central point is there, that you have to have two these things which has to be done. One is check the diagnosis, re-evaluate the comorbid disorders, whether they are, and accordingly reach to a conclusion. Then pharmacological treatment, there are two basic major treatment source we have pharmacological. One are the benzodiazepine receptor agonist or benzodiazepine receptor modulators, and another is a melatonin receptor agonist. So check out, if it is improved, it is fine, continue, follow up for the efficacy, side effects, optimal duration and discontinuation, check out for that. If not improved, then add the cognitive behavioral therapy into it, go for cognitive behavioral therapy, still it is not helping, then go for re-diagnosis, re-evaluate the things again, and because of that, if there is an improvement, what you can do again is you can change the benzodiazepine receptor agonist in that case. If improved, then continue the same treatment. If not improved, then add or change it to sedative antidepressants. So antidepressants which are having sedative effect, we can say that these are the sort of first generation one, like tricyclic antidepressant type. So we can go for that. Then if it improves, fine, we can continue the treatment. Now lastly, all these are showing no improvement, then what we can do? Then we will go for combinations like benzodiazepine plus sedating antidepressants, still not improved, then go for again re-evaluation, re-diagnostic, and check it out. If it is improved, then we will continue for that. This is what our algorithm for the treatment of chronic insomnia. Now these are various drugs which are available. We have got various benzodiazepine receptor agonists or modulators. We have got melatonin. Particularly if you remember, those who have written about sleep and the maintenance of sleep, there are various neurotransmitters which are responsible for that, and melatonin is an hormone. Those who have given about it, particularly about sleep, definitely you can just, or those who have not seen it, please refer those who have written about melatonin. Melatonin is a very, very important hormone from pineal gland which causes the maintenance of diurnal cycle of the person, or we call it as a normal schedule of the person. And that is why when there is a evening, this melatonin is released after darkness is there. Because of this darkness, this melatonin causes the depression. It is aiding the sleep, and during sleep it is also responsible for reaching towards the deep sleep, which is important one. Melatonin secretion is prominent in the phase of before midnight. After midnight, gradually, even if person sleep, but again the secretion will not be that more. Melatonin is known for many, many protective benefits it is showing. It is a sort of antioxidant. It helps neurons to have a good repair activities. and there are many functions. If those who have not seen these things about melatonin, please go about pharmacology of melatonin. And this melatonin is, that is the analog of it, that is rameltion. So these are various drugs which are available. We shall see individual drug how they are used, how they can be used. Now why we are treating, we have got our goals. For each treatment we have got various goals. That is what we are going for, improvement in the sleep quality and time. Sleep quality means we have seen various depths of the sleep, deep sleep, isn't it, REM, NREM, and various stages of sleep. So we want that it should be resembling to the natural sleep. Now this is very important. In what way? Suppose somebody is sleeping 8 hours, but the quality is not good, or there are very frequent wake-ups and not able to reach to the deep sleep, then the quality is not good. And then even if the person is sleeping rather more time than the normal requirement, still it is useless. So both are important. Sleep quality as well as time, both should be good. There should be improvement in the insomnia related daytime impairments, like improvement of energy, attention, or memory difficulties, cognitive dysfunction, fatigue, and somatic symptoms which are appearing because of the this insomnia, and daytime work is affected. It should be brought towards normal. Then there should be improvement in the insomnia symptoms, that is sleep onset, then wake up, and all, in intermittent awakening, like that. The onset should be less than 30 minutes. The wake up and sleep after that should be again less than 30 minutes. Then there is a decrease frequency of awakening, and other sleep complaints should be reduced, because intermittent awakening and problems are associated with it. The total sleeping time should be greater than 6 hours, and sleep efficiency, here efficiency means quality related, should be greater than 80% to 85%. Then we say that yes, our treatment is working, or we are reaching towards solution. Formation of a positive and clear association between bed and sleeping, improvement in the sleeping related psychological distress. This all are our goals, and accordingly we can go for treatment for that. For to achieve these goals, we have got a treatment. So we shall go for various psychological and behavioral therapies, and some nutritional therapies, and then sleep related therapies. So what are these therapies which are behavioral treatment are there? We shall go for that. So these are example of this is stimulus control is designed to extinguish the negative association between the bed and undesirable outcomes like wakefulness, frustration, and worry. So these negative states are frequently conditioned in response to effort to sleep as a result of prolonged periods of time in bed awake. Means person is going to sleep but cannot sleep, is lying on the bed, and once that time goes beyond 30 minutes, usually person should get asleep within 30 minutes of lying on bed. But if it goes beyond that, then it starts thinking and all other things are there. So then it gives various stimulus which are we can say that these are negative. So objective stimulus control therapy are for the patient to form a positive and clear association between bed and sleep, and to establish the stable sleep wake schedule. So what we can do in that case? The instructions can be given: go to bed only person is feeling sleepy. If not feeling sleepy and lying on the bed, then as I told you, it will make the person rather not sleepy, because so just when the person thinks that he is going to have a sleep now, just before few minutes before the person should go on the bed, avoid naps before that. Use bed only for sleep, not for other activities like reading over there, or before sleeping I'll lie on the bed and read the book, like that. So if unable to fall asleep or back to sleep within 20 minutes, remove yourself from the bed, engage in relaxing activity till drowsy, then return to bed. This is how they are instructed. Repeat as necessary. Patient should be advised to leave the bed after they are pursued not to sleep within approximately 20 minutes. Rather than actual clock watching should be avoided. Again, same thing should done during awakening. So once the person wakes up, then should not lie on the bed. And if the person understand that is not going to sleep in next 20 minutes, then should get up and do some other activities. Then go for relaxation. Again, the person should go for relaxation, for muscle relaxation, guided imagery or abdominal breathing. These are various exercises, they can be suggested by the experts. These are designed to lower somatic and cognitive arousal status, which can interfere with the sleep. Relaxation training can be useful in the patient which are displaying the elevated level of arousal, and they are often utilized with the cognitive behavioral therapy. So these are instructions are given accordingly, and go for that. How to go for muscle relaxation, the breathing techniques, and relaxation of mind, decrease in the thinking. These are various ways by which it can be done. Then cognitive behavioral therapy for insomnia. So it is called as CBT1. It is combination of cognitive therapy coupled with behavioral treatments like stimulus control and sleep restriction, as we have seen earlier. With or without relaxation therapy, cognitive therapy seeks to change the patient's overvalued beliefs and unrealistic expectation about sleep. Cognitive therapy beliefs means overvalued belief, and unrealistic means they should feel that within after lying on bed within this much time they should get sleep, this kind of sleep they should get. This should be the patterns of sleep when there are some underlying stress or something is there. So many things are there. So accordingly they can train, they can made them clear about it. It uses a psychotherapeutic method to reconstruct cognitive pathways with a positive and appropriate concept about sleep and effects. Whatsoever distortions are there, these distortions are identified and addressed in course of treatment. I can sleep without medication. I have chemical imbalance. If I can't sleep, I should stay in bed and rest. My life will be ruined if I can't sleep. This type of beliefs are there, should be removed. Most other things other are understandable, but one is, if I can't sleep, I should stay in bed and rest. This type of thinking should not be there. If one cannot sleep in next 30 minutes, should get up of the bed, do some activity. Do not, because this, as I told you, it goes in thinking that not able to sleep, and that's thinking itself can cause a big hindrance. So therefore, if cannot sleep, then get out of the bed, go for some activities, and then when will be drowsy, when about to sleep, then come back for that. Other thinkings are definitely very negative. One can't sleep without medication. I have chemical imbalance. My life will be ruined if I can't sleep. So these are very what we can say highly polar one, highly negative in that way. Definitely they are 100% no, but this one cannot be pursued by people many a times. Then multi-component therapies without cognition therapy are there. Various combination of behavioral therapies and sleep hygiene education. So simultaneously many things are combined. Again here many things means here no drugs are involved, again no pharmacological treatments are there, and many therapists use some form of multimodal approach in treatment of chronic insomnias. Then sleep restriction, initially time limits the time in bed for total sleep time. Then this approach is intended to improve the sleep continuity by using sleep restriction to enhance sleep drive. So whatsoever sleep is there, it is restricted so that slowly person can reach towards the deeper sleep, Suppose earlier person was sleeping maybe 6 hours, then slowly gradually can be reduced it. No afternoon sleep, no other sleep, go for more fatigue, go for physical exercise. So this will increase the sleep drive. The window of opportunity for sleep remain restricted. As I told you, no daytime napping. It becomes more consolidated, and when sleep continuity substantially improves, time in bed is gradually then increased to provide sufficient sleep time for the patient to feel rested during the day. So this is how it can be there. There are various instructions are given for that. Will not go into detail of this. Then paradoxical intentions, specific cognitive therapy in which the patient is trained to confront the fear of staying awake. So it has to be told that, because once that fear goes, fear, anxieties, they are the biggest obstructions in sleep. So remove that fear, remove that anxiety, and it can help in improve the sleep. Then biofeedback therapy, it trains the patient to control some physiological variable through visual or auditory feedbacks. The objective is to reduce the somatic arousal. So go for that and check out whether there are some somatic arousal is responsible for that. Then this physiological variable can be controlled uh, if these somatic arousals are there. And sleep hygiene therapy is there. It involves teaching the patient about healthy lifestyle practices that improve sleep. It should be used along with the stimulus control, relaxation training, and sleep restriction or cognitive therapies. Here instructions are there, but they are not limited to keeping a regular schedule. Suppose regular sleeping time somebody makes around 10:30 or something like that, then try to cut off from various activities and try to sleep at around that time. Have a healthy diet and regular daytime exercise. I already told you about diet timing also, particularly evening meal, or that is dinner, should be much, at least there should be around 1.5 to 2 hours gap between sleep and your dinner. Quiet sleep environment, avoid napping, caffeine, other stimulants, nicotine, alcohol, excessive fluids. Excessive fluids make problem that if somebody takes excessive fluid in the evening, then they causes fluid level increase in the fluid level, that causes stress on kidney, that causes it produces more urine, and because of that this signal goes for micturition. So person has to go for urination multiple time. So these are then because of that, because again this signal goes to brain, and this signal will cause person to wake up, go for that. So once that person wakes up and goes for this, then the sleep is breaking, or it is not a sound sleep. So if it can be avoided, then this is what sleep hygiene is there. So these are stimulating activity. As I told you, anything which can be stressful, may it be movie, it can be reading book or something which can be stressful, then it should be avoided exactly before that. So these are various therapies which can be and these are what all are the behavioral therapy. These are the non-pharmacological therapies which should help the person to get the sleep. This can be possible only in condition which is not severe one, or which is what we can say, which is not a insomnia, which is sort of organic because of certain chemical changes which has occurred. These are mostly because this is reason behind this is basically because of some stressors, or because of inadequate sleep hygiene. So in that cases, if it can be tried, it can be maintained, it will be helping. Otherwise, if it is organic because of problems related to uh, sleep related things, then in that case it will be we need a pharmacological treatment. So this is how we can go for this. Then treatment wise, you have seen the pharmacology. Please refer pharmacology again. Various drugs, their pharmacokinetics, pharmacodynamics, their pros and cons. Their in pharmacokinetics, definitely have an eye about. You can take it as a sort of, you can make the chart, number of drugs which are available. Their pharmacokinetic means what is the onset of action, what is the duration of action, what is the half-life of these drugs. This will definitely help you to understand the drug selection process, because on what basis we can select the drug. Example, the person is having a problem in sleeping, that is the initiation of sleep, then, and if the drug has got this one, we can say long onset of action or late onset of action, maybe onset of action may be around 1 hour, then it is useless because person has to sleep. Or then you have to guide the person accordingly, that at least 1 hour before the tablet has to be taken. Okay, if the duration of the action is suppose less than that, or half life is less, there are two things can possible. If the half life is too less, then person can woken up somewhere in the middle. Or if the duration of action is beyond few hours, maybe 8 hours, 10 hours, then the person can remain sleepy despite good sleep. So these are all things which can be taken into consideration. Go through it, go for various ideas of the drugs. This will help in formulating a good pharmacological treatment, or the what we can say good algorithm for that. Then we can move towards various drugs. The drugs are known to you basically, as we have seen. Most of the drugs, they are acting on, we can instead will make it as a drug acting on GABA receptor. That will be more appropriate instead of benzodiazepine receptor, because benzodiazepine acts on GABA receptor, barbiturates acts on GABA receptor, and many other drugs are acting on GABA receptors, which can improve the GABAergic activity. Okay, is one thing. And second thing is the drug which are not acting on these mechanisms. Example of these are melatonin like drugs and miscellaneous drugs. So we have got these various groups of drugs, and from that how to select drug. Basically benzodiazepines are the first line of treatment, they are the first choice, and we shall see them one by one, what are the treatments. After that, what other treatment we can go for. I think here also you have seen it. Let me check it. Yes, we have seen it. Basically first line treatment in recent graph, the different benzodiazepine receptor agonist or ramelteon. So these are the first line. Okay, in always it is a first line. If not, if first one has not worked, then we have went for the different one. So we shall go for these various drugs which are drug one by another, and then this will complete our insomnia and drugs acting on sleep. Please go through, as I told you, go through the anxiety disorders, what they are. Anxiety or panic disorder they are usually called. There are various kind of anxiety situations, general panic, and many such more. So please go through this, try to understand the basic mechanism behind it, or basic reason behind it. These are again all related to neurotransmitters present in the CNS. And one more thing is that after that we shall be going for this OCDs, that is obsessive compulsive disorders. So go through what is the basic behind it. Most of the drug treatment you have already seen. Either in panic disorder or anxiety disorder, we can use the drugs like sedative hypnotics or benzodiazepine type of drugs, rather we can say. And for this OCDs, we can use drugs which are used in case of depressions. So these are various treatments option we will have. Go through it, classification as you have studied in pharmacology. Then we'll go for various diagnostic tools and what we can say, various treatment options or treatment algorithms for this. If you have any difficulties, you can definitely post this on our therapeutics group, so that we can see that we are solving it, we are trying to answer it. Okay, so take care and be safe.